Hello everyone, myself Dr. Kashif Shaikh. I'm a diabetologist practicing at Baiklaves in Nagpur in Mumbai. So we are going to discuss a case. There is a newly diagnosed type 2 diabetes with high baseline HbA1c levels. Patient is Mr. AB, 45-year-old with newly diagnosed type 2 diabetes, visited clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated with metformin with advice for lifestyle and diet modification. Recently, he visited again as part of routine checkup. His laboratory workup showed following records. HbA1c 8.5, EGFR 80, LDL 80, HDL 38, triglyceride 200. Medication started was metformin 1000 milligram twice a day, lisinoprol 40 milligram QD, metoprolol 100 milligram QD, and atorvastatin 40 milligram QD, and aspirin 75 milligram QD. Physical examination showed BMI 31, blood pressure 120/70, and heart rate 78. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complication in type 2 diabetes. UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was apparent even though no difference in HbA1c levels between the intensive and conventional therapy. When metformin is not suitable and empagliflozin linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in patients with high baseline HbA1c levels. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7% compared with metformin monotherapy. For patients with HbA1c more than 1.5% above goal at diagnosis, ADA and EASD guidelines recommend first-line treatment with dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease, chronic heart failure, congestive heart failure, or chronic kidney disease. EMPA and LINA combination with a complementary mechanism and pleiotropic benefits may be suitable option across a range of patients, including those with established ASCVD or high risk, established heart failure or CKD due to the tolerability of the combination, in addition to the potential benefits of empagliflozin on cardiovascular renal outcomes, and no increased risk of heart failure with either agent. According to study, early achievement of HbA1c less than 7% with empalina could reach target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by empalina has demonstrated 1.81% HbA1c reduction at HbA1c baseline, more than 8.5% at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieving HbA1c less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve the target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infection associated with SGLT2 inhibitors has been reported with when a DPP4 is added, perhaps but because of a better glycemic control, although other possible mechanisms remain to be investigated. In the summary, empalina combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individuals agents with low hypoglycemic risk. Thank you.